Welcome everybody. Can you hear me? Very good. Apologize for the noise, Sarah. But Sarah Conci is a candidate for one of our positions here in physical therapy, and she's going to give a presentation today for about half an hour, 40 minutes, and then we'll have some time for questions after. And I would ask that you speak loudly because we're also recording this when you do ask your questions. More to come, and I'll just let Sarah take over from here.
Thank you, Reg. So thank you for having me here today, and thank you all for coming, both in person and whoever's out there online. I was invited to give a presentation today to introduce myself, to tell you a little bit about my teaching experience, and also to give a lecture-style presentation on a topic that would be relevant to entry-level physiotherapists. So I'll start off with an introduction. This is my name, and these are some of my favorite pictures. A little bit of background of where I come from. I'm from Winnipeg, born in Winnipeg, lived in Winnipeg for most of my life. I attended the University of Winnipeg, and then I lived away for about 5 years. I spent 2.5 years at Arizona State University, where I did a research master's degree. And after that, I went to the University of Alberta for the physio clinical master's degree. And when I graduated, I came back home to Winnipeg. I got a job at Health Sciences Centre in acute care, and that's where I've been ever since. I started as a staff physio, became clinical advisor, and now over the past few years, I also do a little bit of work at the U of M in the physical therapy department, teaching some lectures and labs in the neuro block of the program. So a little bit more about my teaching experience. I started in 2012 as a tutorial leader. Nancy Ryan-Arbay invited me to lead some tutorials in the older adult course. I don't remember what it was called at this moment. And then I started doing mostly work as clinical instructor. So in acute care, in the neuro block of placements, I had 4 students together with me at Health Sciences Centre. I did that for a few years in a row. And after that, I started taking on some more lectures and labs at the U of M in the neuro block. This is what I currently have that's listed here under 2018-2019. 7 lectures, a large group tutorial, lots of different labs together with Becky, 1 lecture in Tony's course. And I also am the coordinator for the Neuro Rehab Clinic, which is run by the PT department. It's down the hall over there is our space. And we have 2 groups of 5 students that come through each year, and we give them a clinical placement with outpatient neuro clientele. Besides the more formal teaching arrangements that I've had through my job at Health Sciences Centre as clinical advisor, there's lots of more informal teaching opportunities. I do lots of mentoring work with the new therapists that we hire. We hire a lot of new grads, so supporting them in their journey, mostly during their first year of practice. And then we also have some, I lead some learning sessions, some informal learning sessions in our department. Therapists from the rehab and children's also attend, and those are primarily neurotreatment-based learning sessions. So that's a bit about me and my teaching experience. The topic I've chosen to talk to you guys about for my lecture presentation today is about patient-centered care and the Therapeutic Alliance. And the reason I chose this topic was because I think it applies to all of us no matter what our area of practice is. It's definitely relevant for new physiotherapists, and I hope to be able to give you guys some practical tips that you can use, maybe both in your work clinically or in the rest of your life also. Lots of communication strategies and things. And there's lots of research evidence to support how important the Therapeutic Alliance is. So it's good for us to think about it. So I'm hoping that we can accomplish 3 objectives today. To first understand what is meant by the Therapeutic Alliance, to understand why attaining a positive therapeutic alliance is important in your practice, and to understand how to do it. How can we create a positive therapeutic alliance with our patients? And I know sometimes people say clients, sometimes people say patients. I think even within this presentation, sometimes I'll say client, most of the time I'll say patient, but I mean the same thing regardless of what I say. So I just wanted to make that clear. This is the presentation outline. We'll talk about some definitions, we'll talk about the evidence, and some tips on how we can create a positive relationship, and then we'll end with a summary. So I've been told I have 30 to 40 minutes. I think we'll be able to meet the target. I hope I won't go too fast. We'll see. I'd like to start by sharing a story with you guys. So those of you who are clinicians or worked in clinical practice, I'm sure you can relate. There's sometimes those patients that just stick with you, or an experience that you had that you can't forget, or maybe change the way you thought about something. So I have a story about the quadriplegic in bed 1. I don't remember lots of details about the story, but I don't remember if I was talking to the patient or talking to a colleague or the nurse, but I had called him the quadriplegic. I remember he was in room 41, bed 1 on A5, the neurosurgery ward, and he was a young man, and he had quadriplegia for some time, and he was admitted to hospital for a surgery revision. So he had a neck surgery revision, and he said to me, "I'm not a quadriplegic, I'm a person with quadriplegia." And it just, like, in the moment, I was just taken aback, and I felt badly that perhaps I had shown disrespect or treated him in a different way, or he was very respectful when he gave me the feedback. And he did a lot of work in, like, patient advocacy, working with the Canadian Paraplegic Association. And since I had that experience, I try really hard to use more patient-centered language. It's not a knee, it's not a back, it's not a CVA, it's a person who has had this happen to them. And so that experience made me think a little bit more about patient-centered care, and it especially made me think about my language. So I just wanted to share that, because that was one of the things that happened early in my career that made me start thinking a little bit more about these topics. So what do we mean when we talk about patient-centered care and the therapeutic alliance? It's hard to nail down a really specific definition for patient-centered care. Different books, articles will describe it differently. So I took some of those pieces and also combined it with my beliefs, and this is the way that I put it into words. Patient-centered care is where the patient is an integral team member in planning and in decision-making related to their health care. The patient is a person first. And then together with that, what is the therapeutic alliance? So the therapeutic alliance is the collaboration, the affective bond, the working relationship between the patient and the physiotherapist. And this bond can be created when there's agreement between the patient and the therapist. When there's an agreement on goals of care, there's a sense of mutual confidence in each other, mutual trust, and you would describe that you like each other. So keeping those definitions in mind as we move forward, do these things really matter? Like, if I'm a good PT, maybe I got really good at my manual therapy skills. I make this really great set of exercises. I get really good at whatever clinical skills I need. Isn't that enough to help my patients get better? Won't my patients be satisfied with their care? The answer to the first question, yes, therapeutic alliance really does matter. So I'll share the evidence with you on the next slide. And the answer to the second question is maybe, maybe not. The best predictor of client adherence and client satisfaction is the relationship between the client and the healthcare professional. And I think this statement can be said like across health disciplines too. There's been lots of research into this area in like psychotherapy and patient and physician relationships, and it's more recently emerging in the field of physiotherapy, the research evidence anyways. So one of the articles that I read in looking into these topics was called, talked about the common factors model. So this idea was created in the field of psychotherapy, and they found that therapy is better than no therapy, but no one specific type of therapy seems drastically better than any other. So this is when you're comparing different sorts of therapies to the same condition, to the same patient population. So there's no one therapy that emerges as like the gold standard. When you have it can apply to physiotherapy too. When you have a patient with chronic low back pain, this is the thing that you do and it's gonna get all your patients better. But therapy is better than no therapy. So when they do placebo trials, therapy is always better than no therapy. So if there's no specific type of therapy that is better than any of the others, maybe it's something else. Maybe it's something about the therapy experience, or what factors are common between different therapies that are helping our patients get better, rather than the specifics of the intervention. So I thought that this was pretty interesting. And this research group, they looked at the field of psychotherapy and what the research showed as what these common factors were that were all different sorts of therapies had in common. And then they thought about physiotherapy practice and what factors exist in physiotherapy that are similar to psychotherapy that maybe these patient results could be attributed to. And so the model that they proposed was, these are some things that are common across different types of therapies, different types of physio interventions. So change processes, that's things like your motivational interviewing, your patient education, goal setting. Therapist qualities, so this has to do with your clinical skills, your professionalism, your knowledge. Also your personality, like are you a warm, personable sort of a person, or are you like flat affect kind of a person? Relationship elements, so the quality of the patient-therapist relationship, the ability of the therapist to listen, to provide feedback, to spend time with the patient. Come on in. The treatment structure, so frequency of appointments, things like that. And then the client characteristics. So what are the client expectations for treatment, and then psychosocial factors. So together, thinking about those ideas and the common elements that might be helping our patients achieve positive outcomes, there's been some review articles and some experimental studies to look at the therapeutic alliance piece of that. So therapeutic alliance, the therapist qualities and the relationship elements kind of go together. And so there's been studies looking at that therapeutic relationship to see how important it is. So here's a couple of summary points from a few articles. So in patients with chronic musculoskeletal pain, an enhanced working alliance contributes to pain reduction and improvement in physical functioning. So regardless of the specific treatment provided, it's this working alliance that is having a large part in helping reduce pain and improving physical function. So more than any exercise program, more than any treatment that you're doing, it's your relationship with your patients that is helping them get better. In patients with low back pain, the therapeutic alliance can predict outcomes of global perceived effective treatment, function, pain, and disability. So again, another review article. And they looked at, oh no, this one wasn't a review article. This one was an RCT. And they compared, for patients with low back pain, general exercise versus motor control exercise. So this is things like working on transversus abdominis and things, and pelvic floor. So general exercise, motor control exercise versus spinal manipulative treatment. More than any specific type of treatment, it was the therapeutic alliance that was able to predict the patient outcomes. In this third bullet point here, another systematic review. A positive therapeutic alliance is associated with improved patient outcomes of pain, disability, physical and mental health. They looked at depression when they were talking about mental health, and treatment satisfaction. And the last one, which I found to be the most interesting because they actually manipulated the therapeutic relationship or the therapist qualities. So they compared IFC with sham IFC, and then they had an enhanced therapeutic relationship where the therapist would go in, would explain the treatment, would answer questions, would do a little bit of assessment, would offer reassuring remarks, and give the patient encouragement. And then they had a limited therapeutic relationship where the therapist would go in, explain the treatment, and then leave. So a limited time and limited interaction. And so they found there was like a dose-response relationship. The enhanced therapeutic relationship with the real IFC patients did way better than the patients with the limited therapeutic relationship and sham IFC or placebo. The other groups did get a bit better, but the enhanced therapeutic alliance was definitely a clear winner. So some interesting studies that support that this really is important. This is something that we should be thinking about and talking about with our students, with our colleagues, and reflect upon ourselves as to how we are implementing it. So together with patient outcomes, these studies talked about patient outcomes. There's also 3 aspects of physio care that determine patient satisfaction. So therapist attributes is the top item that can influence patient satisfaction with our care. Also the process of care and the organization of care. So the process of care is like how quickly could you get an appointment, the frequency of appointments, follow-up appointments, stuff like that. And organization is like, did they have a good parking lot? Is it close to my house? Were they open at times that was convenient for my schedule? So now that we know that the therapeutic alliance is really important, it can help our patients get better, it can improve patient satisfaction, which is important wherever you work. Maybe you work in private practice and you're wanting to improve business, recruit more patients. Maybe you're working in a hospital and you want to decrease length of stay, help your patients get better faster. We know that it's really important no matter what. So what can we do to be better at it, to create these positive relationships? So there's lots of information out there, and there's some different models that are proposed. When I was looking at summarizing things, I felt like everything fit into these 3 categories. So how we listen to our patients, how we respond to our patients, and then our physical behavior, how we act and what we do. So I hope in this section that I can give you guys some practical tips that you might be able to take away. Those of you who are clinicians, you can try them this afternoon and see what it feels like. And those of you who are instructors, perhaps when you're interacting with your students, you can think about some of these things as you move forward. So the first piece of it is listening. How do we listen to our patients? It's really important to allow the patient to tell their story, and it's really important to allow uninterrupted time. So I went to a course that was talking about therapeutic relationships about 1.5 years ago, and what they told us was that typically we only allow our patients to speak for about 10 to 14 seconds before we interrupt and ask a clarifying question or move on to the next thing. And it was suggested to maybe try and give your patients about 1 to 2 minutes to let them talk to you and share their story. So that's something that you might try or pay attention, how when I'm having a conversation, how quickly do I interrupt? Maybe try and make that period a little bit longer. That being said, not all patients will come to you ready to talk for 1 to 2 minutes. They might be a little bit more reserved depending on what their issue is or what their personality is. So in that case, in the respond section, I'll give you some tips on how to draw information out to them. Another item that I could have chosen to put under listen or respond is to clarify physical problems. So you can ask them questions about what's going on. I'll leave it at that for now. We'll talk more about asking questions later. Find out what the aggravating and alleviating factors are. It's important that we practice active and reflective listening. I'm going to clarify the difference on the next slide. It's important to engage the patient in problem solving. They want to feel like a team member. They want to be involved in decision making, and ask for feedback. Ask the patient how they're doing. Maybe it's during manual treatment. You could ask, is this feeling okay? You can ask them how they're doing. Ask for feedback. So I mentioned active and reflective listening. So active listening is something that I've heard about a lot, and reflective listening is terminology that I hadn't heard of as much. There is some overlap, but there is some differences. So active listening is where you be attentive, you signal understanding by using vocal inflections and head nods. So we can practice these things as we're talking with our patients. You have a non-judgmental open body posture. So this is like, I feel like pretty common knowledge. It's important not to sit with your arms crossed, your legs crossed, but to have a more open body posture. Reflective listening is where you engage in conversation and reflect on the patient's story. You can paraphrase back what they said to you. This helps them understand that you're paying attention and makes them feel like you understand what they're going through. Because oftentimes patients are coming to us because of a problem. Something is wrong and they need our help. And they want to know that you understand. Thank the patient for sharing. Be empathetic. So feeling together with them. Let them know that you're on their side. You can understand, or if you can't understand, you can just say things like, that must be really hard for you, or things like that. There's a difference between empathy and sympathy, so we're gonna run out of time for this video link down here, but this was the best little video that I've seen that compares empathy versus sympathy, and it really helped me understand what empathy was. And it's a video, there's like a little fox, and he's not feeling good, and he has like a rain cloud above his head, and then he crawls down into a hole and he's just really bummed out. And then empathy is a bear comes along and he like climbs down into the hole and he just be's grumpy with the patient and they have a hug and it's nice. And then sympathy is like there's a goat that comes from the top and is like shouting down the hole like, hey, are you guys okay? Aw, that's too bad. So it's a cute video. If you have a chance, you can Google these words, Brene Brown, empathy versus sympathy. So if you have one of those patients who isn't going to talk to you for 1 to 2 minutes, you can ask questions using open-ended questions. So tell me, when I'm gathering a patient history, I always ask, tell me about your home. Tell me about your family. If they can answer you with a yes or no or one word, then it's not an open-ended question. What did that mean for you? Or so seek clarification using open-ended questions. So that's the listening portion, some tips that you can use as you're listening to your patients tell your story. The second piece of it is respond, so how you're going to respond to your patients. It's important to use language that's at the patient level. Acknowledge the patient's life outside of rehab. This is a way of practicing patient-centered care also. It lets them know that you recognize them as a person more than just their stroke, their knee injury, their back injury, their COPD, whatever it is you're working with them. Demonstrate empathy comes up again. Engaging in problem solving comes up again. Validating their experiences. They want to feel like you're in their corner. You're in this with them. Conveying a belief that they'll get better, be able to self-manage their condition. Providing clear explanations is important. showing sensitivity to their emotional concerns, specifically their emotional concerns. So I feel this makes me feel, my knee injury makes me feel frustrated because I can't play soccer with my friends. Oh, that must be so frustrating for you. I can imagine that that's really difficult, that you can't be part of that anymore. Providing encouragement, answering questions, being honest, and being clear. So some of these are a little bit vague, but I encourage you to take it back and think about it. This is a picture of my optometrist. I saw some quizzical looks as that went up there. So I'll share another story with you. So being from Winnipeg, growing up in Winnipeg, I've had some health professionals that I've been seeing since I was a little kid. This is Dr. Georgie. She works at Village Optical, and she's been my optometrist since I was a little kid. And I always said to my mom, like when I was a teenager, I was like, I wish all my doctors, not that I have lots of health problems, but you have a dentist, you have a doctor. I wish everybody could be just like Dr. Georgie. Like, I really like her. And she always seemed to know about me. I'd only go see her like once every 2 years, right? So how could she really know me or what was going on in my life? But somehow she always did. And I wasn't really sure how this could be. I was like, man, she has an amazing memory or something like this, right? And then one time, probably a few years ago, I realized she takes little notes as you're talking to her, and then you go back 2 years later and she's like, oh, so are you still working at Health Sciences Center and riding your bike to work every day? And then you have a little talk about that. So she does a really good job of acknowledging my life outside of our healthcare encounter. And because of that, it makes me feel more comfortable to divulge more information or feel more comfortable in that setting. And I also really like this quote, people won't remember what you said or what you did, but they'll remember how you made them feel. So that's another of my little stories. So those are the tips on how you can respond to your patient or engage them in discussion. And the last piece is about how you can act. So what can you do? How can you behave that will help you develop these relationships between your patients? So these are some more specific practical things that you can do. The first one on the list is positioning yourself at the same level or lower than the patient. So perhaps you're in a private clinic and you're going to have a patient sitting on a plinth or a table. Instead of standing, looking at them, perhaps you could be sitting on a chair beside them, sitting on a wheelie stool with them, greeting the patient with an eye contact and a handshake. This is something I think I could do better at. I don't usually greet my patients with a handshake, but that acknowledges them as a person rather than as a patient. Eye contact is a little bit more controversial. There's mixed findings whether eye contact is good or not good. It depends probably on your patient, if they feel threatened by it or if it makes them feel like you're interested in them. So be careful about that one, but handshake can be good. Avoid barriers between you and the patient. So this includes like bed rails, laptop computers, and tables. So I started doing this a long time ago and I've got out of the practice, but I work in inpatient, so most of the time I'm greeting a patient who's in a bed. So if you can walk in, lower the bed rail, maybe have a seat beside their bed and have that introduction conversation. I'm Sarah, I'm the physiotherapist. This is what I'm here to do. Tell me about your home and your family or something like that. Laptop computers and tables too. So I could stand here behind here and that might be a little more impersonal, or I could stand here and hopefully it's a little bit better. It's a little bit, this one's a little bit tricky too, because you probably have to take notes as you're doing your patient interview, right? So if you can identify some sort of a way where your computer can be at the side, or you can finish your assessment a couple minutes early to jot your notes down while it's still in your memory, or have the computer down on your lap instead of up on a table right in between you, can be really helpful. individualizing the treatment program. So there's many qualitative studies in this area. Patient interviews in many of the qualitative studies, they want to feel like they have a special program that's just for them. So if you hand them the same generic exercise program as anybody else, they feel like they're just another knee, just another back. But if maybe you are giving them the same set of exercises because this is what you found to be effective in your clinical practice. But if you take the extra couple minutes to just jot it down in handwriting or maybe change something on your usual handout that makes it feel like it's just for them, it can really help increase the adherence to the program and improve outcomes and satisfaction. Follow through with what you say you're going to do. Going the extra mile is perceived as positive by our clients. So maybe you looked something special up outside of work. If you can relay that back to the patient, they really appreciate when they perceive that you're going the extra mile, you're in their corner, you're in it together with them. Taking time, avoiding distractions, acting in a warm and personable way, I feel like is straightforward, smiling, displaying a friendly attitude. The other thing that came up is about the use of touch. You have to be careful together with this one, same as with eye contact. Patients come with them a history, psychosocial beliefs. You don't know if there's something that they're not disclosing to you. If you touch them, it might make them feel uncomfortable. So try your best to read the situation, but most of our work is physical. We end up usually touching the patient at some point. So when you do project confidence, this is it's a professional sort of a thing. Other people will talk about, like, if they're seeming sad, you could put a hand on their arm, stuff like that. I feel like that you have to be a little more careful about stuff like that. In one of the articles, there was some very clear behaviors that you should not do. These were things that contributed negatively to the relationship. So don't cross your legs. I was a bit surprised by this one because I feel like crossing your legs demonstrates like a sense of comfort, or like, you lean back, you cross your legs, but don't cross your legs. It's perceived badly. Don't have an asymmetrical arm posture. I don't know the context of this, but like I find I often sit at like a table like this, but then I'm like, oh, maybe I shouldn't. And today when I was talking to some of you folks, I tried to go like this instead. I hope that helped. Don't orient your body away from the patient. So if your computer is over here, maybe don't be like talking to them like that, and try not to rush. So when you go back to work this afternoon, pay attention to your postures. So some other ideas. So I took the ideas that I read about and I compiled them into these 3 categories. I also read this really recent article by this research group from Alberta where they created like a model. They proposed a model to try and help guide people through creating a positive therapeutic alliance. Most of these things listed on this slide are similar to what we've already talked about, so I'm not going to go through it item by item, but there is one thing that's bolded there, and that's giving of self. So that's something new that this group proposed based on qualitative research. So showing empathy falls into this category, but also disclosing aspects of your own personal life. So my example is I have a cat, and his name is Zeus. Does anybody else here have a cat? So a few people. So now we have some common ground. We can talk about cats and their favorite toys and whether they cuddle with you or not. Disclosing aspects of your own life helps the patient recognize that, it makes them feel like you see them as a person. And is perceived positively in building that relationship. So that was something new that came up out of this. Some people aren't comfortable disclosing things about their lives, but it gives you a chance to pick and choose what you're going to talk about, right? I can talk about my cat, rather than like my family situation if I choose, right? Common ground is the other thing that kind of fits into there. If you can find some sort of common ground that's not related to the therapy or the medical, whatever reason is the patient is coming to see you for, if you can find some common ground, that helps you see each other as people, develops that mutual trust, mutual liking of each other, and can help you achieve that positive relationship. Use of the body as a pivot point also came out as a theme in this study. We've talked about some of these topics already. People are usually coming to see us for something related to their body, some sort of a physical condition, and so it just grouped those things together in that category. So, in summary, the take-home messages that for you guys to think about in leaving today: regardless of the area or setting of practice, establishing positive therapeutic relationships can improve your patient outcomes. It can improve patient satisfaction and help you be a more effective therapist. And to create a positive therapeutic alliance, you can use active and reflective listening, respond to your patients with empathy, acknowledge the patient as a person, be careful in the language that you choose, put the person first, and try your best to act in a warm and personable way. These are the references that I used, which if anybody's interested, I can provide later. And that is all that I have to say, and I'm happy to answer questions about myself or this topic area or anything else that you would like to talk about.
Thank you, Sarah, for that interesting session on therapeutic alliance. If anybody has any questions on that, or maybe even developing a therapeutic alliance with your cat, which is very interesting.
He's pretty cute. Look at him.
Questions? Yes, go ahead, Joe.
Thank you for that presentation. That was really interesting and a good reminder of what we should just be doing in our everyday lives, I feel like, not just with patients. My question is not related to your topic. It's just kind of a more general question.
Sure.
So you've done a lot of teaching in neuro, I understand. Are there other areas of practice that you have had some experience teaching in or would feel comfortable in teaching?
Sure, good question. So most of my work is in neuro. I work in acute care neuro. Together with that brings complex patients that don't usually fit into a box. So I have clinical experience doing like cardiorespiratory treatment, secretion clearance, things like that. Sometimes people will come with a brain injury and a fracture somewhere or other orthopedic issues. So practice is more general in some circumstances. I'm interested in lots of different topics, so I would be happy to teach in other areas also. I'm interested in like interdisciplinary collaboration, things like that also. Things like therapeutic alliance, professional issues. I don't have any specific like I want to teach that or I do not want to, maybe like outpatient ortho, like manual therapy skills and stuff like that would be like my weakest sort of area of knowledge in terms of clinical practice. But yeah, does that answer your question?
Other questions? Thank you, Sarah, for the presentation.
Thank you. Thanks for coming, everybody.